All right, good morning, good afternoon, everybody, wherever you are in the world. My name is Sarah Hess and I work at the World Health Organization in Geneva. Welcome to this webinar. It is a slightly different format of a webinar that we're doing today, and I'm very excited to be presenting the topic and introducing our panelists. Today, we're going to be looking at the role of faith partners in the COVID-19 pandemic response, with a special highlight on Sri Lanka. We have with us participants or panelists from the WHO country office in Sri Lanka, from the national health authorities in Sri Lanka, and from faith partners. And really the purpose of this webinar today is to have a discussion around the collaborations and joint efforts between national health authorities, WHO, and faith partners in responding to the COVID-19 pandemic. We're all aware that across the world, faith partners are playing a very critical and instrumental role across diverse areas in the COVID response. And so we really want to try and shed the light on some of those and amplify these best practices. And so to get going, I will just say a few housekeeping rules. We are recording this webinar. We're streaming it live on YouTube, so the recording will be available afterwards. And to get going, I'm going to hand over to my colleague Sahani, who sits in the Sri Lanka WHO country office, to introduce our panelists. Sahani, over to you.
Hi, everyone. Thanks, Sarah. So I'll just do a quick introduction. And first of all, I want to thank our panelists for being with us here today. We have Dr. Sapun Vijayasinghe, who is a consultant community physician at the Health Promotion Bureau at the Ministry of Health in Sri Lanka. Mr. Praveen Gomez, who is the head of programs and strategy at the Alliance Development Trust in Sri Lanka. And Mr. Suveen, who is a national professional officer for mental health in at the WHO country office for Sri Lanka. So again, thank you all for joining us. And
thanks very much, Sahani. Oh, I lost you there for a bit, I'm afraid. Sorry about that. Okay, great. So I think to get started with the discussion, we'd really like to hear first off from the WHO country office, Suveen. Suveen, could you enable us to set the scene for this webinar? And please, can you tell us from WHO's perspective in Sri Lanka about some of the critical roles that civil society plays, in particular faith partners, in supporting the local response to health emergencies? Suveen, over to you. Suveen, you're on mute, I'm afraid. We don't hear you. I think we should be able to hear you now. I see you are unmuted.
Thanks for giving the opportunity to participate in this significant discussion. I think this role of faith partners in the pandemic response, as you are aware, that's working with civil society organization is really important, because engaging with communities at the ground level is essential to health promotion and creating a real and sustainable change. As a WHO as a technical agency, we does not always have the network or resources to reach the target audience on our own. Therefore, partnerships are crucial to our mission. In a country like Sri Lanka, working with faith-based partners like religious leaders can be particularly effective due to their extensive network. The most recent census shows that 99% of the Sri Lankan population identify themselves as faith. So religious leaders are considered respected and trustworthy sources for information. Additionally, several major religious holidays also occurred during the COVID-19. So the These holidays are mostly, they celebrated very traditionally by the mass gatherings and communal events. In order to control the spread of COVID, it was vital that we engage with faith-based partners to appeal to communities and encourage everyone to adhere to public measures. Together with MoH, we worked with religious leaders in disseminating messages that urge the community to stay at home and maintain all physical distance and all kind of protective measures. These leaders also encourage the people to stay at home and communicate with their loved ones through the phones or social media, and also offered a kind of an insight on how to celebrate on this non-traditional way. Could be just as meaningful to safeguard the community. Once the COVID-19 restrictions begin to ease, working with faith partners was crucial to ensuring gathering for the worships were conducted in a way that reduced the likelihood of transmission. So we prepared the guidelines with the help of the Ministry of Health and WHO and circulated among the faith leaders and community leaders to convey this message to the people. So there is it is really highly necessary to develop a kind of a two-way kind of communications between the target audience and the people. So we will get the feedback right. We can easily identify the gaps and misinformations in the community and provide a proper messages to the community through these leaders. So currently WHO is supporting all this. There are 2 CBSOs to work with religious leaders in health promotion and sustainable behavior change programs in 6 districts, few village communities. I think we can hopefully in few months' time, we can give more details about the outcomes of these measures, how the faith leaders' role in doing this community work or protecting the people from this transmission or kind of a special settings like this. Over to you.
Thank you very much for your response and for highlighting the importance of two-way communication, listening to feedback, and then the really valuable role of engaging faith leaders in the dissemination of messages that have been co-developed and co-created. So thank you for that. I'm going to hand to Sahani now, who may pose the next question.
Thank you. This question is for Dr. Sapun. Could you please share with us some insights from the pandemic response in Sri Lanka? In particular, how the collaboration between the Ministry of Health and faith partners has helped to address these challenges?
Hi everyone, I'm Supun Vijayasinghe from Sri Lanka, Ministry of Health. Sarah, can I have the slides, please? Wonderful, yeah, great. So thanks, Sahani. First of all, thank you so much for inviting us to present about the role of religious leaders and the interfaith networks, the activities that we have been doing for the past half an year. So basically, if you take Sri Lanka, we actually have about 3,380 odd cases up to now, 3,374 to be exact, and 13 deaths. So the government of Sri Lanka was quite positive, and they were very keen on when the epidemic was there. So there was a huge response from the government side from the beginning for the pandemic. That's why we had a lot of things under control at the moment. And on top of that, we had a very robust public health health system where we were able to respond rapidly to the needs of the country during the times of the pandemic. So basically, a lot of activities have been done in case finding, contact tracing, case management, and quarantine procedures, and Triforces of Sri Lanka, and timely involvement of the government of Sri Lanka, as well as the health sector, did a wonderful job to keep the epidemic under wraps and not to make it, let it go rampant in the country. So I'm going to focus on the response and basically related to role of the religious leaders and the interfaith networks, the activities we have done. So basically, I represent Health Promotion Bureau. So risk communication is a component that is directly coming under us. It's the area that we are usually working in, and the risk communication systems. You have the internal and partner communication, public communication, capacity building, then rumor management, and last but not least, the community engagement component. So the role of the religious leaders and interfaith networks usually come under the community engagement and public communication aspects of the risk communication plan. So basically, I'm going to focus on the areas which is on next slide, please. In this slide, so how we have utilized the religious leaders and the interfaith networks in our country to effectively overcome the COVID-19 in Sri Lanka. So basically, we as a South Asian country, we didn't have that much of cases because of the robust public health infrastructure, but messaging was very important for a country like Sri Lanka, because we have about 6 million users using social media, and our mobile phone usage is about 140% of the population. That means nearly 28 million people are having mobile phone connections. So we have a very large social media sphere. So what we actually did was we immediately, when the messages are created, we distributed that through the interfaith networks. Especially Praveen will talk about it later, where we have used the social media networks like Facebook, WhatsApp, and many other traditional and non-traditional ways of transmitting the messages to the ground level. Because you know, when it comes to rural setup, Sri Lanka has three sort of communities, like urban, semi-urban, or probably rural, and then estate communities. So to send the messages to that level, it's very important that we have grassroots level workers, and we had a lockdown. So probably through the network of interfaith religious leaders, we were able to send a lot of messages, and most of our messages were shared via WhatsApp and Viber and many other platforms. They were, the religious leaders were able to amplify these messages and distribute these to communities. The other aspect I want to talk about is the stigma reduction. In Sri Lanka, there were a lot of cases reported from Muslim community. So because of the crowding and living close together, number of cases were reported in the communities where there were urban, crowded urban undersettlement areas. So there was a huge stigma from the society, and people were, trying to sort of discriminate one religion and saying the disease is transmitted through this sort of a sector. But on the other hand, the people who are discriminated, they are saying, why do we need to contribute to the national effort because we are being discriminated? So there was a lot of negative messages in the social media sphere as well as the community. So as the government and the Ministry of Health, we were able to send positive messages to the community. In an instant, what we did was we took quotes from Quran, and we were able to say staying at home is important. It's mentioned in these holy transcripts. So similarly, we have developed a lot of messages using this, and we were able to send the messages to mosque network in Sri Lanka, in especially the Colombo or the Western province, where a lot 180 mosques were able to send the messages to Muslim community. And the government messaging was also there. So there was a synchronized effort to reduce stigma. So a lot of people were facilitating contact tracing after this messaging. So that's the second point I want to. And the third one is, as Suvin correctly mentioned, we developed with the WHO help community support network, or probably the network where a lot of community-based organizations like Sarvodaya, which is one of the biggest organizations working at the community level, and when the interfaith leaders and many other community-based organizations, through them we were able to build a platform, so we were able to synchronize our activities effectively. And these people were working at the ground level, so grassroots level. So a lot of activities like building places to wash your hands, and you pasting messages or posters in rural setup, and sending messages by these WhatsApp and Viber groups were one of the key things we did with the religious as well as other community-based organizations. The fourth one is we got a lot of support during the Vesak festival, one of the biggest religious festivals in Sri Lanka, where a lot of social gathering and people were crowding to religious places. So this was in May. It was like, a lot of people were expecting to mobilize here and there, and they were were going to religious places. There we were able to counteract that effectively through stay at home and celebrate Vesak by lighting a lamp at home. So that campaign was started by the Buddhist priest, and it was quite successful, and a lot of people stayed at home. So we were able to prevent the spread of the disease to the masses, because a lot of people were expecting there were a lot of gatherings and social gatherings and celebrations were occurring during that period, but it didn't happen because the religious leaders, we were able to work with them and send the messages through the temples to the community as well as mass media that stay at home and celebrate Vesak by lighting a lamp. So this was one of the successful activities that we have done during the May-June season. The other activity that we actually did was we started a behavior surveillance from the beginning. This is a general behavior surveillance. Risk communication is two-way. We need to listen to people. So behavior surveillance is basically you are just checking whether they are receiving the messages, whether they are understanding what we are sending, and whether they are able to perceive the risk and perceive the threats of the COVID-19, and what are their attitudes, what are their beliefs, and whether they are actually adhering to the identified positive good behaviors. So basically, the behavior surveillance network was established by the Health Promotion Bureau. We engaged support of a lot of community-based organizations. And they were sending feedback to us when the messaging is there. They will say, okay, we have understood this message. We didn't get the last message you have transmitted. So we were getting a lot of feedback. So we were monitoring the feedback by online surveys, direct calls to the the community groups, as well as Facebook posts, and engaging the people. Once you post a message, we were monitoring the Facebook networks, how many people are engaging in these interactions, and how many people are commenting for the messages we are posting. So, and UNICEF also did a wonderful job. They did 2-3 cross-sectional surveys, and this also gave us a lot of material to develop messages. So behavior surveillance network was one of the key activities where we use this network to cater our messages to the community. So we were at a point aware what is happening in the community and what is the population's perceptions about the disease and what sort of messages that we should develop for them. This was quite important because we did a one behavior survey for from the beginning when the hospitals were segregated, and we were like, when people were admitting, a lot of negative messaging or negative feelings were there in the hospital sector among doctors. So we were able to pick this early and develop appropriate messages for these activities. From the religious side, that the religious leaders in the communities were sending a feedback to us. Probably we had a 1999 hotline where they can call us and report many things, and they can directly talk to us. There were doctors answering the phones, and they were like listening to what is happening in the communities. And so these activities were the ones actually we did. Can I go to the next slide, please? Wonderful. Okay, so basically we had an existing interfaith model we have established a long time ago. We use this system for leprosy as well as stigma prevention and many activities. This model focused on the public health inspector and all the faith-based leaders in the society. So if you take a district, the Christian priest, Buddhist priest, Hindu priest, Muslim priest, and whoever the other prominent religious leader is part of this committee. So they were actually engaged in message amplification as well as helping a lot of people during the time of lockdown. So that's all I want to say. If you have any questions, I'm happy to answer. Over to you, Sarah.
Thanks very much. I had to do a quick office change as there was some serious drilling going on next door and I couldn't hear anything. So apologies for that. Thank you very much for your really insightful sharing. I think there definitely will be some questions. So I'd like to invite all the listeners, if you do have questions, we'll take some at the end. So please put them in the Q&A function of Zoom and we will try and get to those as we go towards the end of the webinar. But in the meantime, I'm really interested to hear from Praveen, because Praveen, I think, was one of the implementing partners in this whole interfaith initiative and model. And I'd really like to hear a little bit from Praveen how you managed to bring faith leaders together. What were some of the challenges that you faced and what were the elements of your success? So over to you, Praveen.
Thanks, Sarah. Yes, good question. What happened was that this faith group was not brought during COVID. It happened way before, 3 years, in fact, before this all came about. Because we built upon an existing model, as Dr. Supun rightly mentioned, because we know forming relationships do take time. What happened was 3 years ago, the Leprosy Mission funded us to involve faith leaders for stigma reduction or to address stigma. And we ran that in parallel with the Ministry of Health. Dr. Supun, in fact, was part of this initiating team. What we did was we approached an existing interfaith group that was easier than reaching out to individual faith leaders. We found that in Sri Lanka, everybody is very religious. And we found that because of the civil war and natural disasters, the religious leaders had set up working together working groups. And one group that we found was called the Interreligious Peace Foundation that had set up for peace building. But years had gone by after the tsunami, after the war, and this group was not very active anymore. So when we met them, we said, okay, if you kickstart your groups in every district, we'll give you a tool for peace building. And they excitedly put their teams back together. Together with the Minister of Health, we went to them and said, if you will leave your differences aside and fight a common enemy on leprosy, well, let's work together. And they did. It was very encouraging because what they did was They rallied the team, as you see on the screen up there. The public health inspector had a team of religious leaders in every district who would support him in his campaign, in his awareness raising. So they would find that the religious leader, one religious leader will say, you know what, the school principal in our area is a friend of mine. And they would go as a team and conduct awareness in that district, in that school. Or a religious leader, say the Hindu priest will say, why don't you come to my temple? And that was the beauty of it. The public health inspector would go there to the temple. The Hindu priest would share first about addressing stigma, about why they need to love people affected. And then the public health inspector will say where to get treatment from. So just combination of those two was so great that when COVID hit, we said, why not we leverage this for COVID as well? So our first step during COVID was that we first reached out to the WHO Sri Lanka, and with their technical guidance, we put a very short response guide to faith leaders. And we shared this via WhatsApp. Now, by sharing that via WhatsApp, what we did was also we positioned ourselves as a group that had connections with the ministry once again, just to reinforce that once again. And then what we did was we took the messaging, the great messaging that was developed by Dr. Supun's team, the Health Promotion Bureau and the WHO. We took their messages and weekly we shared it via WhatsApp with these faith groups. And they in turn shared it with their communities. What we saw happening there was credible information being shared with community influencers. And we thought that that combination worked really well. And that's not all. We understood that domestic violence or violence against children could be on the increase. So what we did was that we quickly got the brochures that I think WHO, CDC, and UNICEF had developed, the parenting tips, and shared that too through this faith group, and they shared it with their communities. We also saw them addressing the vulnerable communities, compassionately, distributing food during the lockdown. That also was something great that we saw that these religious leaders on their own started engaging. Sarah, sorry, I went through all these without really going through the slides. If you can just flip through the slides. So here we see a photo of the planning meeting where they got together to plan. Yes, next please. So this is the statistics on the first 9 weeks on the faith messages that went out through the faith groups. We saw it kept increasing. More and more faith leaders started getting involved, sharing these messages. So by the 9th week, we had over 40,000 messages going out weekly. Next, please. And here's the parenting brochures translated into the local language. Here's for teachers. Yes. Again, another school program. Yes, I will end with those photos. But that's what happened right through right through post-lockdown as well. Sarah, you asked an important question on were there any challenges? Yes, there were. One is we know that before COVID struck, we had this vast network of faith leaders who were able to conduct face-to-face awareness raising. But during the lockdown, we had to limit it to only those who had smartphones. So that significantly reduced the numbers that we worked with. Then we also saw the data limitation. Yes, they had smartphones, but not everybody had the data, the bandwidth to share these week in, week out. So that too, what we did was we reached out to the leprosy mission once again, asking if they could share at least with the district coordinators, whether they could fund some of these so that we can continue to get the message going. And the third challenge that we didn't face it, but we foresee that we may have is the new infographics that need to keep coming out weekly. If we are to just keep that momentum, that excitement, that interest going, we cannot share the old messages. It needs to be different. We need to see the new material being churned out weekly. And that would, I foresee as probably a challenge in the future. Yes, thank you, Sarah. Over to you.
Thank you so much, Praveen, for sharing with us. I think there was a lot of rich information in what you shared. I think particularly the use of existing trusted networks, the fact that it takes time to build trust, and really that is, in terms of sustainability, the way to go is to take the time to build the trust and to build the networks and to use what's already there and what's already working. And also, I mean, to me, what came across very strongly was you're stronger together. So if you have the faith partners and you have the Ministry of Health and you have WHO working together and you're aligned and you're building off each other's strengths, certainly there can be successes. But so yeah, thank you so much for sharing with us. I'm going to hand to Sahani now because I believe there are a few more questions. Sahani, over to you.
Yes, thank you very much. I just had another question for Dr. Sapoon. What other health challenges has the COVID-19 pandemic exacerbated in Sri Lanka? If you could just tell us a little about that.
Hi, yeah, thanks, Shahani. Overall, I think at the moment we are facing a big challenge when the country will be open to tourists. We will need a lot of testing facilities, so that's a challenge that we foresee. And then how to quarantine people and contact tracing. So we need to think more on the side of using technology like mobile apps and many other related technologies. From the side of the community, now what we have seen now from our behavior surveillance is that the interest in the public is now coming down because nobody is seeing that much messages as opposed to what we have seen in the beginning of the year, where a lot of people are dying from COVID, a lot of people are being hospitalized. Now it's not getting broadcasted, so the perceived level of threats and the perceived level of severity of the disease from our side is a little bit coming down. So people tend to not follow the positive behaviors like wearing mask and washing hands and social distancing, which is one of the biggest problems we are facing, maintaining a 1 meter distance. So that those things are now challenges as opposed to what has been there 3 or 4 months ago, because people saw a lot of damage due to a lot of death due to the disease, and the perceived severity as well as the threat level was high. So for us, it was easy for us to nudge people into good behaviors because they are seeing a lot of risk at their individual level as well as household level as well as community level. People perceive that this would affect me, my family, and my community. But nowadays, I think the level of perception or the severity level has come down, and a lot of other issues have come up. So we need a lot of strong messaging. We need continuous behavior surveillance, which we are doing at the moment. So those are the challenges we are facing in Sri Lanka at the moment. Over.
Thanks very much for sharing with us. I think it's not unique to Sri Lanka that there is definitely a certain amount of fatigue around the world in how people are needing to respond and behave, and so yeah, we see that everywhere. I'd like to now go back a little bit to Praveen and ask you. This work, you said, was built from the leprosy response and translated into a COVID response. And do you see that there is the potential for taking the lessons learned here and applying it to other responses or health crises in the future? And if so, if you could name the sort of top 3 lessons learned and key elements of success, what would they be?
Sure, Sarah. Good question once again. Yes, definitely we can apply this lesson to future responses. In fact, when we did start with the leprosy campaign, we did not know that this would fit nicely, beautifully into a COVID response. So definitely this can be applied in future. My first lesson learned would be to partner with an existing network. There's no point reinventing the wheel. As you also highlighted, building relationships does take time. Let's look for the structures that are already existing and build upon that. Then the second point is that do not work in isolation of the Ministry of Health. I think that's very key. We need to empower the duty bearers to build, to support the Ministry of Health and not to work in isolation. And that is something that sometimes religious leaders are afraid to do. And that's where I believe even an NGO can come in to help bridge that gap, to bring the faith leaders and the ministry together. And thirdly, we need to remember that there is more to it than just the virus. There's hunger, there's the violence, and faith leaders could be mobilized in that aspect as well. But for that, there's training would be needed. You could mobilize them for home-based care for mild cases to support the MoH. Like, for example, what I was talking about, the parenting tips to address the violence in the home. I mean, we have a orphan crisis around the world. For all these, training would be important. Fourthly, you asked for three, but I would add in a fourth. And it would be good to provide, for example, the PPEs, because faith leaders probably should be classified as essential workers if they're going to help in this crisis. And I would say to even maybe to go to the extent to compensate them so that their data charges can be covered and they can actually support the ongoing epidemic if there is one in the future. Yes, Sarah.
Thanks very much, Praveen. Very clear lessons that we can hope to take forward and document. Sahani, over to you.
Great, thank you very much. And just a final question for Mr. Savine. The COVID-19 pandemic has highlighted the importance of mental health and providing support and services. As our resident expert on mental health, what role do you believe faith partners have in promoting mental health and well-being?
Good, Sahani. Sri Lanka, this is not the first time Sri Lanka is using the religious leaders or the faith healers. During the first tsunami, Sri Lanka has utilized the faith healers partners that's mainly they train on them communication skills and major mental health conditions. So they normally, while performing their duties and rituals, they help to listen to the people, their problems, and provide befriending to the needy people. They are also skilled to detect and refer the issues to the mental health services. So faith-based personally, I have partners had a good role, did a good work during the post-tsunami period. So we use the same method, same methodology during the COVID also. During the COVID time, people are mostly worried and they are fear of infection, losing their loved ones and staying for quarantine for a long period and lockdown. So there are social isolations, losing their loved ones. There are a lot of issues, psychological issues are there. And also there are issues like relapses and worsening the existing mental health conditions. So during the time, the Ministry of Health taken a lead and had a kind of a coordination with all the partners like community of practitioners, NGOs, FBOs, and WHO and all this international organization. They not train fully, but in a pilot study like work, they train people in certain areas and pass all the messages to the faith healers because they are the people have a ground level contact and all. So they given a very basic mental health messages and all kind of messages to the people. And the other side, the directorate and the districts provided medicine for the people who need it, or the existing patients, they given a 2 months medicines to them. They deliver to home, some are posted. So some people can go and collect from their nearby clinics. So the primary care also fully supported them to the existing patients. But to the other issues like the people with fear and kind of a less motivation and having fear, they utilize the faith leaders, because faith leaders are mostly trusted by the community, and most of the time people get advice from them. So for the mental health services, they use variety of service providers, and the faith healers provided a major big role in supporting the mental health work in the country.
Thank you very much for your response. I want to now allow a little bit of time for Q&A. So again, I say to those listening, if you do have a question for a particular panelist, please do input it into the Q&A function, and we will see if we can answer some of those. We do have a few questions already, so thank you for submitting those. The first one I think would be good for Dr. Supun to try and address. This comes from Mosde, who says, were there any cultural issues among the people of Sri Lanka that made it difficult to implement the guidelines and social distance? Over to you, Supun.
Thanks, Sarah. Very good question, and I think it's a very important one. Yes, I think there were a lot of cultural issues. If you take South Asian countries, we were struggling with social distancing because, you know, our public transport system, a lot of overcrowding is there. So a lot of people are not used to queues. Queuing in public, it was very difficult. So culturally, we have a sort of our marketplaces are like bazaars. So a lot of people are close together and they are moving, and people are not used to social distancing. However, having said that we were able to use nudging, the certain behavior, you know, tactics like marking the places, like, you know, 1 meter distance. We were able to mark 1 meter distance at the ATM machines, supermarket queues, you know, pharmacies, grocery places. And so that behavior was, you know, actually adhered. When you see certain things, people tend to follow the, you know, the markings, and they keep the meter distance. And we were able to send messages everywhere. We were displaying social distancing, or the keeping 1 meter distance is important. So continuous messaging was there. And then the most importantly, Ministry of Health has developed a guideline. So workplaces, you have to maintain a social distancing, and 1 meter distance was important. So banks and hospitals and many other people were on board in that sense. And they were like security guards monitoring it at the entrance. So a lot of activities were there to enforce this because mere messaging will not help you in a communities like Sri Lanka and probably you know, other South Asian countries. You need to have certain enforcing from the point of entry into supermarkets or places of you know, work, or places of, you know, like schools, etc. So we had a problem, but it was overcome by using those measures. Right. Thank you, Sarah.
Thanks very much, Dr. Supun. There's another question from Mwai. Welcome, Mwai. Mwai was with the World Council of Churches. So Mwai is asking, and I wonder if Praveen, you want to speak to this a little bit. What do you envisage to be the role of the faith leaders and faith community in post-COVID rebuilding, especially to build back better?
Great question, Mwai. Brilliant question. And I do see a big role that faith leaders can play. The firstly, I would say, is that we could leverage the influential power of religious leaders. We should not underestimate that the influence that they have over their community, over their congregation. So if a positive message needs to go out, definitely this is one route we can use to leverage this. Secondly, I would say the compassion. Yes, work can be done on the ground to build better, but without the key ingredient of compassion, which the faith leaders do come with, it would not be the same. And that's the role that I believe that any faith leader brings into the table. And thirdly, I would say that they have their ears to the ground. So if, for example, post-COVID, I mean, when we look at it once it ends, we would see that it would have impacted and affected quite a few people in the process. And I guess the religious leaders would be having a ear to the ground to know those who were impacted, to identify them, to make sure that no one is truly left behind. Thank you.
Thanks so much, Praveen. There is another question that's come in regarding mental health. So Suveen, I wonder if you would like to speak to this one. Lara says, as you know, there are a limited number of people who are allowed to attend the funeral rituals, which pose further mental health problems to the families and relatives of the dead person. How did this group contribute to supporting mental health when somebody dies from COVID-19 in the absence of the cultural ceremonies? Suveen, do you have any comments on that question?
Okay, yeah. And because Sri Lanka didn't experience much on this area because there are only 12 deaths, I think, 12 or 13 deaths in Sri Lanka. That's also mostly old age people, and there's a mixed group. But mostly that's the faith groups, that's they mostly in the, during the time, the faith leaders or the religious leaders normally continuously communicate with the families. And also we provided that hotline like 1926, it's operated by National Institute of Mental Health. And there's another number 1333, that's compassion. And they also provided support to these families during the time of crisis.
Thank you very much. Does anybody else want to make any comments regarding that question? All right. So I think we're almost at time, and I want to thank everybody for being here today, for sharing their insights and their wisdom and their experience. I think it's been a very rich discussion, and there will be a lot that we can try and document from this and share. So I think for each of the three entities, WHO, the ministry, the national health authorities, and the faith partners, there were definite elements, I think, that lead to the successful working together that we can try and amplify. I mean, I heard from WHO's perspective, of course, working very closely with our national health counterparts, trusting them and feeding back to us the cultural nuances and the information needs from within the communities and the country is something that we can really facilitate. And also, as Praveen mentioned, I think in supporting faith leaders in their role, ensuring that there is training available, materials for them to share, and that they're well equipped to do the incredibly important work that they're doing. And then I think it's extremely admirable from the national authorities that they play that role of really bringing all the people around the table who need to be around the table to be working together. So the importance of having that interfaith group that is already there existing, a trusted network that can just be leveraged and brought into action when needed. And so I think that that's a really important one. I think something that Praveen mentioned in terms of the challenges is the issue of the kind of digital divide. So when the whole world had to move virtually to conduct their affairs over Zoom, as we're doing now, and email, to really make for us to have a deep awareness that this is only a certain proportion of the population, and to really make sure that we are going beyond just those who are digitally connected. And I think Praveen, your one quote that you said, "Leave the differences aside to fight the common enemy," I think is a really great motivation for the working together. And so I'd like to thank everybody for being here today, for our colleagues in the Sri Lanka Country Office for this great collaboration, and Praveen and Dr. Supin for sharing your experiences, and to all the participants as well for being here, submitting your questions, and we look forward to continuing these conversations in different countries. So thank you to everybody, and I do wish you a really wonderful rest of the day.
Thanks.
Thanks, everybody.
Thank you.
Thanks, everyone.
Take care. Bye-bye.